Hello, everyone. Welcome to another round of virtual morning reports or afternoon or evening reports, wherever you're joining from. So happy to be here and glad to discuss a case today with Yaz. We have a change of schedule a little bit, and Zakaria is gonna be presenting a case to us today, which I'm super glad about. Zakaria, do you want to say hi and tell us a little bit about what's going on today?
Hi everyone, my name is Zakaria and I'm a medical graduate from South Africa, currently doing my internship in Cape Town, um, and excited to share this case that I saw actually this weekend with you all.
Very excited. Thank you so much for being here today. And then we have in the scribing and teaching point position, I think Ibrahim and Rahul. Is that correct? Do you both want to say hi?
That is correct. Hello, everyone. My name is Ibrahim, and I'm a final year medical student based in Saudi Arabia. Happy to be here today.
Hello everyone, I'm Rahul. I'm from southern part of India. I'm an incoming PGY1 into Yale Waterbury Hospital into internal medicine. I'm very excited for the case today. Thank you.
Yeah, thank you both so much for scribing and teaching points. And last but not least, Yaz, I'm so excited to co-discuss with you. How are you doing today?
Hello, friend. I'm very happy to be here. Honestly, I'm also a little bit nervous for the as an incoming PGY1 too. But yeah, I'm always very happy to join the VMR with you all.
Yes, I think it's the first time that we're discussing together. Is that right?
I think it is the first time, yes.
So excited. Yeah, I think whenever we have the whiteboard up, Zakaria, you can start with the case.
Sure. So this is the case that we saw this weekend. So the patient is not fully worked up, but we do have a diagnosis. So I'll start. Chief concern is that a mother brought in her 16-year-old daughter, previously well, now with altered mental status. And I'll stop there.
Yes, do you want to start?
Oh, of course, definitely. Thank you. So it is very interesting because we have a very young patient with altered mental status, and the key word here, I think, it is that she was previously well. Meaning, I'm getting this image that this is sudden, and that the first thing I would do after the ABCD approach, see that this patient is stable, I would think something metabolic, that it's just presenting. Like we don't know if this patient has a past medical history of diabetes, like hypoglycemic episodes. I would like to know, or hyperglycemic. So I'd like to know if this patient may have like diabetes mellitus type 1, or any other type of diabetes inside of the like mosaic of type of diabetes types. Another thing, metabolic would be something endocrine or something as a toxin, or if the patient is on any type of medication, also try to explore those sites. That would be for the hyperacute setting in a previously well patient. Again, and another thing that we normally mention on young patients is bad luck, bad genes, or bad behavior. So that's another thing that I would like to throw in there. What do you think, Elena?
Yeah, I absolutely love how you highlighted that a young patient at the age of 16 should not be sick at all. And altered mental status is always very concerning. And whenever we have and see that in the ED, I've just started working there in the last week, it's very important to secure that the patient is stable. So we go through our ABCs to make that sure. And then you went like perfectly through the altered mental status schema that we have on the website. and it's basically the missed mnemonic. So we think about metabolic causes, which you've alluded to, and then we can think of infectious causes inside the brain or outside the brain, structural causes, and toxins, withdrawal or intoxication. I think we highlight this a lot in neurology VMRs, but I think it's the same for internal medicine as well. So it all boils down to time course times localization. So maybe we can try and make a little bit more progress here. I'm not 100% sure what the time course of this altered mental status is, but I'm assuming just because of the context that we have so far, it has to be acute or even hyperacute. And that's when we really think about all of the things that you've been mentioning, Yaz. And yeah, I think it would be interesting to just learn more about the patient as we move forward, because sometimes like it really matters if the brain is inherently vulnerable or if it's not. We see a lot in older patients that it just takes like one little push, like a pneumonia, for them to be altered. We see delirium in the hospital very, very often. But if this young patient is presumptively healthy at baseline, yeah, I think it's super, super concerning what could be going on here. And yeah, maybe to latch on a little bit more on the schema, I think despite what you said for the metabolic causes that we think about, it definitely is important to get a sugar up front. So like hypo or hyperglycemia, as you mentioned. But then also other, like especially organ dysfunctions that we can think about. So maybe the kidney is on the hook, maybe the patient has an underlying liver disease and now is altered because of hepatic encephalopathy. And then any signs of infections. And I think I would start with things that are inside the brain. So looking for meningismus, is there any clue that the patient might be having meningitis? Is there a fever? And then, yeah, with this, it would definitely be like meningoencephalopathy. And if we can get any more clues into like that direction, I'm less thinking of just like a infection that is outside if the patient has a functioning brain at baseline. And yeah, and I think structural is also very important too. So always asking for trauma in these kind of patients, like a severe head trauma can alter the patient's baseline. But then also like thinking about like just a post-ictal state. So has the mother maybe seen the patient having a seizure? And even if the patient is like still that young, we should do a thorough history about like drugs and really ask for that if there's like any intoxication or withdrawal from something. Yeah, curious to learn more, Zakaria.
Okay, wonderful discussion. So the mom says that the daughter is at baseline well and functional. She's a high school student living at the school residence, so she's a boarding student, and she was just home for the weekend, and she hasn't really seen her much lately. So she doesn't know much about her usual state of health in general recently, but she does say that the patient is usually well, takes no medications, no alcohol or drug use that she's aware of, and no history of any illnesses. And like I said, not on any medication. Mom also reported that the episode this morning occurred. It occurred around mid-morning. While the patient was seated, she began slurring her speech, and she seemed confused. She was then later on profoundly weak in all four limbs and sort of collapsed on the floor. And the mom was worried about a stroke, so she called emergency medical services. And I'll stop there.
Yeah, yes, maybe we can just take turns if that's fine with you. Yeah, so what I heard is that we learned a little bit more about this episode. And Zakaria, I have just like one or two more questions. So if I heard you right, then it
Sure.
seems like the patient has been sitting on the table with their mom, and then suddenly they started to have this like slurred speech, which I translate into dysarthria, and then they like fell on the floor and were collapsed. Was there any like seizure noted, and was the patient like then going back to baseline?
No history of any movements or anything like that, and patient not at baseline, been like this ever since.
Okay, I see. Yeah, it seems like this is really like hyper acute neurological syndrome. So I think when I hear this arthria that is like acute in onset, yeah, I usually think of, I always have a difficult time like differentiating it from aphasia. But I think the way I remember it is that aphasia is really a problem with speech. So so speaking, like you can't find the words or you don't understand. And while dysarthria is really a problem with language, so you have like some difficulty to like form the words. But if you have, if you were watching a movie and you would put like the words under it, you would be able to understand. So it's oftentimes, I think, localized outside the brain, but I think in this context, it could definitely fit, for example, as seizure. And seizures don't always have to be convulsive, so it doesn't need to be that the patient doesn't need to like have like this tonic-clonic movements that we typically associate with seizures. So yeah, and then the patient seems to have collapsed on the floor. So it seems like the patient was no longer able to have like enough strength to like stay in the position that they've been at before, which makes me even more concerned that there could be like an electrical discharge in the patient's brain going on at this point. I think it doesn't really fit the picture of syncope too much. I think when we see somebody like falling and going to the ground, we often want to know, like, is it more like a syncope kind of picture, or is it potentially seizure? And some of the clues that would point you more towards a syncope is that oftentimes, if they have not had like severe head trauma or something like that, they would go back to baseline. So some of the most sensitive findings for the patient actually having a seizure is a post-ictal state. So that is what Zachariah is talking about. So the patient is still confused and still not back to their baseline. And then something that we would look for on the exam would be a lateral tongue bite. Yeah, very worried about this patient at this point. I'm curious to learn more, like how they arrived at the AMS, EMS, and if they were still in like this kind of state. Yes, what are you thinking?
Yeah, no, awesome thoughts, Elena. I think that you did a very thorough analysis of that, framing this case as a possible seizure. Now, I would like to also bring to the table, what if this is syncope, like trying to frame another side of this case. Again, as you very well mentioned, that this patient did not have any movement, or they don't mention a tongue bites. We can also like try to explore another option that would be syncope in this case, like review like if there were any prodromal symptoms on this patient, like ask the mother if she noticed any sweating, any like if the patient mentioned if she was dizzy, if she had nausea, or they mentioned Zach mentioned that this patient was just sitting, but sometimes syncope can happen like without any precipitating factors, but also ask if that day this patient had been, I don't know, under a lot of stress, or she did a lot of exercise. And as soon as the patient wakes up, evaluate for confusion, if the patient is fatigued, if there is weakness. Why? Because we should also like look for other signs, like specifically cardiovascular, have a proper, I would definitely add in my workup EKG, a 12-lead EKG. I would also think about like maybe this could be something congenital that we had not seen before, or to evaluate possible exposures. We know that this patient does not have any health-related behaviors, no alcohol or drug use, but it will be interesting to know if this patient, I don't know, went traveling, were on a school, I don't know how you say that, like school trips, try to see if, for example, again, not to anchor here or not to show bias, if this patient went out and I'm assuming this patient is from South Africa. I'm not sure how prevalent arboviruses are there, but one of the arboviruses that can present symptomatically as a neuro syndrome is West Nile virus. It's only like in 1% of the population with West Nile virus that present neurological symptoms, but I will also like determine how feasible would it be to, or if it's justified to do a lumbar puncture and a PCR of the CSF. So yeah, that will be like my try to like frame this as another seizure versus syncope. And yeah, excited to hear if there's more information, Zach.
Okay, wonderful discussion. Unfortunately, we couldn't obtain any further history at the time because the patient was still quite confused. So we opted to go straight to the examination. In terms of vital signs, temperature was 36.8 degrees Celsius, heart rate was 112, blood pressure was 145/87, respiratory rate was 20, and saturating at 98% on room air. And in terms of a spot random glucose, it was 2.0, which translates to 36 milligrams per deciliter. And I'll stop there.
Then I can tackle this just to see if I listen well. The glucose is 36.
36.
Oh, so yeah, that honestly, in practice, I've only been a primary care practitioner back home, but I find more difficult to take care of hypoglycemia rather than hyperglycemia. In this case, this could be absolutely the case of why we had it could had triggered a seizure, we could have triggered or a vasovagal response. Now I'm thinking the next steps would be IV fluids, reposition of glucose. And honestly, I'm not very sure of how to do it because I never did it myself. Think about other metabolic causes, or if this patient definitely, like I would ask for like all this metabolic panel, thyroid, absolutely everything to see if this patient just had this, like it's not a like she doesn't have type 1 diabetes, for example, or if this is something that just triggered a hypoglycemia. Also assess the nutritional state of this patient. Again, this is a very delicate space to explore with patients, and try to be very mindful to assess if the patient has access to food, or if they don't have a eating disorder, or any other previous like things that she might have mentioned. Yeah, like what do you think, Elena? This is very interesting.
Yes, you called it so early. It's very interesting. But I got it right. This is hypoglycemia, right? Okay, because we're all like using different like millimole or milligrams. Okay, I love that in this context, as you mentioned, the management is before we think of all the differentials that can lead to hypoglycemia. And I think one other thing that I thought of is that usually the way we diagnose like true hypoglycemia is not only by measuring it, but you need two more things, and we call that the Whipple's triad. So we want to have like symptoms, so neuroglycopenic, and we obviously have that with the altered mental status of the patient. They often have also like we call that in German, vegetative signs. So like autonomic signs. So we can see that, for example, with the heart rate of the patient. I don't know if they're sweating or anything else, but this is also a feature of symptomatology of hypoglycemia. And the third thing we need is response to treatment. So what we want to do in this patient, I'm not sure if the patient is able to tolerate oral glucose. I'm presuming they're not. Is what we can do is either go for IM glucagon, which is something that we can easily do, but it's going to take some time for the glucose to rise. So what I would actually do is get IV access and give the patient glucose IV. And usually, if that's the only reason why the patient is altered, we should see a pretty quick response to treatment. And that is when we really know that this is hypoglycemia. And yeah, for the causes that we can think about for patients with hypoglycemia, I think some of the most common things that I have seen in the hospital is actually, but I'm only seeing like older patients, is actually insulin or sulfonic urea that is being overused. So everything that can, from a medication side, can drop the glucose severely, and that's really the most common thing. Some of the other things that I have seen is if patients are really, really sick, they can also have low sugars, they have a low reserve. If they're, for example, have an infection, they're septic, that's something that I commonly see. There are certain patients that are at risk for hypoglycemia too. So patients who take who have an alcohol use disorder, who have kidney disease, who have liver disease. And some of the other things that we can think about is adrenal insufficiency. And I also thought about this in that patient. I think what makes me lean away from adrenal insufficiency at the moment is the heart rate of the patient, but wouldn't this could still be adrenal insufficiency and would be something that we can look for. And yeah, and then there's some more like rare things that we can think about with hypoglycemia. But I think what really strikes me from the presentation of what all the things that we know so far is it really seems like hyperacute. So actually, I wanted to add this in the previous aliquots that for me, if this is like really truly hyperacute and the patient was like totally fine at baseline, the things that I would actually prioritize is like an electrical discharge or like a vascular event. And like a hypoglycemia to me is a little bit unusual to really have this like hyperacute onset of symptoms. So maybe I know Zachariah, it was hard to get more information on this patient at the moment. But yeah, I'm really curious how the patient did the days before or the hours before. And I think really response to treatment and seeing if hypoglycemia is the only cause of this right now is really important. Yeah.
Before you continue, Zach, I think we can, after all this amazing information you gave, we can try to frame our differential diagnosis. The chat is on fire, and I'm really, I'm always very impressed. So the first thing we would like to do in this patient is to determine exogenous versus endogenous causes of this patient. We could ask for insulin, C-peptide proinsulin levels, beta-hydroxybutyrate. This is to evaluate the alternative food production. If their patient is not producing enough, like the metabolic pathways are not working well, the beta-hydroxybutyrate levels will be abnormal. So we can think, well, as many of you mentioned, exogenous would be this patient taking insulin or sulfonylureas, as Elena mentioned, or she has an insulinoma or something like more obscure. We can also think about any other hormone deficiencies. That's why it's important, as Elena rightly pointed, to look for adrenal insufficiency or even hypopituitarism, but that will bring us any more stuff to the table. Like this patient would have not been normal baseline. I also like the chat comments of non-islet cell tumors. We know that islet cell tumors can produce IGF. Don't remember if 2 or 1. Someone correct me in the chat. And also think about any inherited metabolic disorder. So far, this is how we're framing in a young patient with a previously normal baseline in acute onset altered mental status and severe hypoglycemia. So yeah, Zach, excited to learn more.
Okay, wonderful discussion. So in terms of the rest of the examination, the general exam, the patient was appearing to be the metabolic phenotype, morbidly obese with a BMI of 42. In terms of HEENT, unremarkable, cardiovascular, pulses were regular, JBP not elevated, S1, S2, no murmurs. Pulmonary exam, patient was undistressed with good airway entry bilaterally. In terms of the abdominal exam, the patient was had an undistended abdomen, soft, non-tender. In terms of the neurological exam, the patient's Glasgow Coma scale was 11. Quite very disorientated speech, but localizing to pain, opening eyes to voice. No facial droop or asymmetry. Pupils were equal and reactive to light. No real limb weakness anywhere. Patient was quite sweaty and diaphoretic. No neck stiffness. Neurological exam was otherwise normal, not really able to ambulate the patient because of a confusion. And in terms of the MSK, it was unremarkable. In terms of rashes, the patient was noted to have a lot of skin tags all around the body and darkening of the skin around the armpits and around the neck. And in the interest of time, I will move on. So with the concern of a possible stroke, the patient was rushed for CT brain. In the interim, obviously, the patient was given IV dextrose, and the patient sort of regained consciousness somewhat, but then was again later on at the CT scan found to be again profoundly weak, with weakness predominantly in the lower limbs. So again, the concern for the stroke. So a patient received a non-contrasted CT brain, which showed no acute hemorrhage, infarct, or mass lesion, no signs of cerebral edema. In terms of a urine tox screen, it was completely negative for all the usual suspects in South Africa. In terms of an ECG, it showed sinus tachycardia and otherwise unremarkable. In terms of a labs, normal urea and electrolytes, normal kidney function, normal liver functions, normal thyroid function, and HbA1c of 5.2. And I will stop there.
Okay. Yeah, a lot of new information there. Yeah, the fact that the patient seems to have adiposity at baseline certainly puts them at risk for metabolic syndrome. And even if the patient is only 16 years old, they could have developed, and that's what we see increasingly worldwide. They could have developed some insulin resistance, but Zachariah and his team have disproven that by the A1C, so the patient has not had a hyperglycemic state in the last couple of months in their blood. And I think I heard that the CT was unremarkable, and that's definitely something that I would have done as well, just because of how sick the patient is. I think I'm still interested in how the patient responded to IV glucose, and if they went back. Maybe I missed that. And something I would add as well, because I think people have mentioned this, non-convulsive status can be really, really sneaky, and getting an EEG is really low threshold. So looking for that as well is really important, I think. For the GCS, I'm just going to add one thing because I've been confused with this before. So usually for the threshold for when we have learned, or at least I learned in med school, for when patients should be intubated is 8. But what we need to know is that those studies are from trauma studies. So trauma in the context of a GCS lower than 8 often requires intubation, but not necessarily here. I don't know what the initial GCS of this patient was. And then we have something interesting. I'm not sure if I can make much more progress there, which is the darkening of the armpits and other areas of the skin. The only association I have at this moment would be acanthosis nigricans. And I think we can sometimes see that even in the context of diabetes mellitus type 2 and insulin resistance. But I'm not sure where we can see that in other contexts. I believe it's you can sometimes see that in different cancers. And you can see that in hyperinsulinemia as well. So I don't know if something like an insulinoma is more likely in this context, but I'm not too sure, and definitely would have to look up what can cause this kind of rash, and would definitely have to prove that it is in fact acanthosis nigricans. Yeah, I think I'm going to stop here and let you tackle the rest, yes.
No, amazing. I'm always very impressed on your skills, friend. I'm very happy to be discussing with you. And you're right. Now we are looking at a normal HbA1c, that it's normal. So that makes insulinoma rise to the top of my differential, because we can see that it's hypoglycemia independent of diabetes. That's the highest probability. I'm not discarding diabetes or any of the different diabetes types that honestly I always have a quite difficult time reading about. So we also should think about, well, this is relatively rare, so maybe I would just send her to a CT scan abdomen. I would not discard any exogenous insulin administration. Always would not take my finger off the asking for the C-peptide and proinsulin levels. I would also ask for a 72-hour fasting. I forgot the name of the test, but it's a 72-hour fast with serial glucose monitoring to look for insulinoma. That's one of the ways that we can try to find if this is or not, as well as morning cortisol, ACTH, to evaluate our adrenal function in this patient. There is another more obscure causes, like test for anti-insulin antibody testing, or again IGF-1 and 2 levels to check for any other type of non-islet cell tumor or any insulin autoimmune syndrome. That would be something very interesting to look at on this patient. And to clear the if I'm not wrong, again in the chat they can fact check me. I believe that insulinoma can also present with acanthosis nigricans. So that's a thing. So yeah, excited to hear more, Zach.
Okay, amazing discussion. So just for the sake of completeness, we have a normal CBC, and all other tests done up to this point were normal. And then further testing was obtained. And by this time as well, the patient had sort of regained consciousness again, and was speaking to us. So the collateral that we got from the patient was that this was actually not the first episode, and the patient described multiple similar episodes over the past 6 months, typically mid-morning to late afternoon. And she said it appears as if she has brain fog, and then she sort of drinks soda or drinks something sweet, She also tells us that she has interestingly gained a lot of weight recently, 20 kilograms over the past year. And she says she attributes it to stress and frequent eating or feeling tired, so she has to keep her energy levels up. No other pertinent history obtained, no family history, no allergies. And yeah, I'll stop there and then we'll have another aliquot.
Yes, is it a good point to have people discuss a little bit in breakout rooms?
Yeah, definitely. I think we have enough time. How many aliquots are there still, friend Zach?
So we can do 2 more.
Okay. Yeah, no, we have some time for like a 5-minute breakout room. I think we do. What do you think, friend?
Yeah, I'm creating them now.
Oh,
Maybe we can
awesome.
pause the
Yeah.
recording.
Because it's very interesting. So awesome. I'm really wondering if somebody would like to share their thoughts in the chat or unmute. Like, please, you can raise your hand. What are you thinking?
I think in our group we were talking that we're sort of leaning toward insulinoma, but I think Obina had like a list of stuff that he wanted to order.
Hello. So yeah, hi guys. My name is Obina. So the reason why we're leaning towards, insulinoma is just from the things we have discussed previously, and also with insulinoma as well. Some of the patients, they have this weight gain as a result of eating a lot to relieve the symptoms of um, you know, the triggers of hypoglycemia, right? So that's is one thing that pointed us towards like insulinoma plus the patient having the hypoglycemia and all of that stuff. So for this patient, we want to check the C peptides and see if the C peptide is elevated as well, as long as the insulin. All right. So if we do this, this will at least I'll say this would point us towards our correct diagnosis of insulinoma.
Thank you, Bina, for sharing your thoughts. Somebody else that would like to unmute?
Hi.
Hi,
This
Satus.
is
Welcome.
so in our breakout room, we were discussing also about other maybe metabolic or hormonal causes such as hypothyroidism, which could be associated with this case, right? She maybe could has been led to insulin resistance by the hypothyroidism. And other thing that we stressed was maybe medication use, like such as sulfonylureas, maybe testing that before going for those more rare diagnoses. I've just thought also about maybe pheochromocytoma, since she's having like this high blood pressure, maybe associated with metabolic disease, but who knows, maybe it's involved in this case.
Thank you, Matheus, for letting us sharing your thoughts. Where are you joining us from?
I'm joining from Brazil.
Oh, bem-vindo. We have a lot of Brazilian friends here. But yeah, thank you. Thank you for sharing all your amazing thoughts. I'm wondering, Elena, would you like to comment something before we jump into the next aliquot?
Me?
Yeah, no, thank you both so much for unmuting and sharing your thoughts, and I hope you had a great time in the breakout rooms. Yeah, I think we don't have a lot of signal for exogenous causes so far, but definitely agree, Matthias, with you that you would have to confirm with checking in the urine or in the serum. I don't know where we get those tests. So I think we're really like in the framework of probably endogenous hyperinsulinism. I think I don't get a lot of signal towards the adrenal gland. I think the TSH was checked. And yeah, I think I'm really like leaning towards insulinoma as well. And I think, as you mentioned, we should get a C peptide. And I think after that, I'm not 100% sure what the imaging modality would be to confirm the diagnosis of insulinoma, but I think it's some kind of like PET scan with like glucose or glucagon avid tracers. Yeah, but would definitely have to look that up, and I think it's a very treatable disease, I think. Yeah, I think it's interesting that the patient has been like dealing with this for such a long time, and I think with our initial concern that this is a hyperacute disease, we could disprove that because it's really yeah, like a subacute episodic disease, and I think this totally alters our framework for AMS, and I think it now fits like much better with the hypoglycemia causing those neuroglycopenic symptoms. Yeah, curious to learn more, Zach.
Okay, so as said earlier, the thyroid functions were normal. Cortisol levels were normal. Sulfonylurea screen was negative. In terms of what you guys asked for, C-peptide was elevated, and insulin levels were elevated. I don't have the exact value. And then beta hydroxybutyrate levels were low. And in terms of imaging, patient got an ultrasound of the abdomen and pelvis, which was unremarkable. And then the patient went on to get a CT and MRI of the abdomen with contrast and specifically pancreas protocol. And that showed a 1.3 centimeter enhancing lesion in the tail of the pancreas. No evidence of any mets. Liver was normal, no lymphadenopathy, and the CT and MRI showed very similar findings.
Wow, super interesting. This is amazing. The fact, so now, before you give us a diagnosis, I think that we have elevated C-peptide, we have low beta hydroxybutyrate, weight gain, this increased appetite, this normal glycosylated hemoglobin, and the normal UTOX in a patient with a 1.3 enhanced lesion in half pancreas. I would definitely like to know. I would put in the first place insulinoma, although it's a very relatively rare tumor, by the way. I can also like I would, if we had the like chance to dig further, maybe we could also try to investigate if this is a non-islet cell tumor. Although a non-islet cell tumor, normally these tumors suppress insulin and C-peptide, and it occurs in older patients. So that's like in the back of the DDX. I'm very happy to see like all the great pearls in the chat. Another thing that for expander differential could be something that we saw like a while back in the VMR. We were talking about this like nesidioblastosis, which is islet cell hyperplasia, because we have endogenous hyperinsulinemia, we have hypoglycemia and elevated C-peptide. But this happens in very, very young patients, I think even in babies. So very important to know also that. What do you think, Elena?
Yeah, great discussion. Yes. I have like very far in the back of my head, I have heard about nesidioblastosis, but definitely have to refresh my mind after this. Yeah, I totally agree. I think in the absence of a family history, I think it's most likely, and also the most common cause of insulinomas to be sporadic. I think they can sometimes, and the chat has been mentioning this, occur in the context of MEN1. So in the context of other like autoimmune diseases or neuroendocrine tumors. But I think they are autosomal dominant. So if the family history is bland, then we don't have any signal into that direction. I'm not 100% sure what the next steps would be if we still need further imaging and like a PET scan. or if we could just remove the mass lesion. Zachariah, I'm very curious to learn more from you.
So well done. The correct diagnosis was an insulinoma. Functional pancreatic neuroendocrine tumor, and that was causing this multiple recurrent episode, neuroglycopenic episodes, and like that was in the context of endogenous hyperinsulinemia. So, like I said, this patient is still currently admitted to our service, and there are some other studies, octreotide studies, and PET scans, but ultimately the surgeons are going to take over the patient for surgical resection. And then obviously then just some teaching points that I can present or learning that I took away from this case was that in the context of stroke, stroke or altered mental status, always look for mimics. And one of those is hypoglycemia. Always check the glucose first. And that's something you can actually treat before you further diagnose to prevent further injury, and especially in younger patients. And then another learning point as well was that this patient presented with the classical Whipple's triad, symptoms of hypoglycemia, and then a low plasma glucose, and then it rapidly resolved with administration of glucose. And then clues again from the history that we got once the patient was responsive again was that this recurrent hypoglycemic episodes without evidence of diabetes, rapid weight gain, and frequent eating, and then, like Ibrahim mentioned, Whipple's triad plus the biochemical abnormalities points with a negative sulfonylurea and elevated C-peptide insulin pointed to the diagnosis of insulinoma. And then further imaging that you can obtain is CT, MRIs of the pancreas with contrast, or you can even do endoscopic ultrasounds, and that can further localize the tumors. And then this patient actually is having recurrent episodes of hypoglycemia in the hospital and is receiving continuous IV dextrose infusions, frequent meals, and the patient hopefully will get surgery soon. And like I said, monitor for other endocrine neoplasms. Thanks.
Thank you so much, Zach. By the way, shout out to Zach because he jumped in last minute as case presenter. He had this amazing case ready. And just to answer a quick question in the chat, the family should get screened if this patient had other endocrine abnormalities, as well as family history, somebody else with issues like hypopituitarism or parathyroid issues, like especially for men 1. If my step training is not failing me right now. So that would be the only reason that we would screen other like serum calcium, prolactin, parathyroid, if we will think this is a MEN1 syndrome. But yeah, Elena, any last words before passing the mic to Ibrahim?
Great case. Thank you so much for that I was able to co-discuss with you. Yeah, let's pass the mic to Ibrahim.
Great case, Zachariah. Thank you for bringing this to VMR, and thank you to Yaz and Elena for the awesome discussion. So we started this case with the differential diagnosis of altered mental status, and we use the best mnemonic here. So typically if a patient comes in and they have altered mental status, you want to think about metabolic causes, and you want to think about a history of diabetes, endocrine causes, you want to do a medication review, and you also want to consider organ failure. So if this patient had a background of liver disease or renal disease, that can definitely result in altered mental status. And then the I stands for infections, and those are typically severe infections. So things like meningitis, for example. The third thing, which is the S in here, stands for structural causes, and you want to think about vascular etiologies here, you want to think about head trauma, and you also want to think about a post-icterus state. And finally, the T stands for toxins. And always remember that you don't want just to assume that this patient had a toxin intake, but they could also be experiencing a toxin withdrawal that can result in altered mental status. And then just because this patient was young, there is typically something that we use on CPS, which is bad luck, bad genes, or bad behavior. It's usually either of those three things in such a young patient who presents with altered mental status or another hyperacute state. And then for the approach to someone who's coming in to your ED with altered mental status is that you want to approach them with your typical ABCs to make sure that your patient is stabilized. And you also want to ensure that you get a glucose check on them. And then Elena helped us in differentiating between dysarthria and aphasia. And if you want to think about dysarthria, just like Elena had explained that as a problem with language, whereas aphasia by itself is typically a problem with speech. And the main reason why you want to differentiate between those two things is because each of these two things can localize to different areas in the brain. And this can help you in building your differential diagnosis. As for the specific differential diagnosis for this case, we mainly were thinking about either a seizure versus hypoglycemia. The hypoglycemia, so Elena had also helped in mentioning the trifecta that you typically see in patients who are coming in with true hypoglycemia. And those are the neuroglycopenic symptoms, the changes in their vitals. So typically those patients would come in a vegetative state, the way that Elena had put it in, and they come in with tachycardia. And then you also want to evaluate the response to treatment. So these patients usually respond to IM glucagon or IV glucose. And then you also want to further dissect the causes that can result in hypoglycemia. And the differential that we built in here was basically an insulin overdose or sulfonylureas. Infections can also result in hypoglycemia. You also want to think about alcohol, liver and kidney disease, and finally adrenal insufficiency. And then we also built a differential diagnosis for the darkening of armpits. And the typical term here scientifically or medically is acanthosis nigricans. And acanthosis nigricans can be caused by diabetes, certain types of cancer, as well as hyperinsulinoma. And finally, Yaz had helped us reach the diagnosis for this case before it was actually revealed by actually noting the hypoglycemia that this patient had that was independent of a history of diabetes. And here you want to think mainly about insulinoma. And the workup can be extensive. However, the gold standard laboratory testing that you want to get is a 72-hour fasting test. This is the gold standard. And once you establish that, you can pursue other diagnostic testing. Typically, the diagnosis of insulinoma is a biochemical diagnosis. So you want to establish that biochemical diagnosis using laboratory testing. And then you want to localize the tumor through imaging testing. And I looked up the imaging, and the gold standard or the gold standard initial type of imaging that you want to get in these patients is typically a contrast enhanced CT before you pursue other more sensitive types of imaging. And that's all for the TPAs for today.
Thank you so much. Shukran, dear Ibrahim. You were talking just like a radiology, and we're 11-1. So passing the ball to Ethan and Charmaine. Thank you so much for joining. See you right now in the next VMR.